So, very good morning to all of you. Actually, we are starting this case, a very interesting case actually. Young boy presents with history of nasal obstruction. For a young boy presents with nasal obstruction, snoring and all, we always think of adenoids. So, and then we generally, do a nasal endoscopy and we think of adenoids. But this child came to me and initially he has been given nasal drops and then sprays, all that. But what really made me suspect was what is called the cotton wool test. Always try to do a cotton wool test in children. This is very, very important carry home message which I want to convey to you. The cotton wool test can pick up many things. The first thing it can pick up is any complete obstruction at the level of the choana, which will never happen in an adenoid. So this patient had a cotton wool test positive, and then immediately I ordered for a CT scan. So I had a diagnosis of either antrochoanal polyp or a choanal atresia. So this was my diagnosis immediately after the test was positive, and you can see here very clearly the left side. It's a clear-cut case of an antrochoanal polyp completely blocking the choana. So that is the most important point I wanted to convey, that all children with nasal obstruction is not equal to adenoids. So I'm going to start the surgery, which you will see now. That the patient had a nasal deviation, and so doing a was difficult. I could see something whitish elevator. So again, always we think of adenoid, adenoid, adenoid. This is the first diagnosis we make. And you see here, this side, you can see the polyp very clearly seen there, which is completely blocking the pathway of air. And second is, I'm going this side, and here, actually, after decongestion, you're seeing this, but when the turbinate was fully hypertrophied, I just couldn't see anything. So it was completely not visible. Here you can see it. Whereas when I was examining in the OPD, I couldn't see that. So this is a very, very tricky situation. So of course, surgery is very simple. That's a different issue. Diagnosis becomes a challenge because one or two doctors have already, tried to give sprays thinking that it is an adenoid, very small child, and you can't do a nasal endoscopy. So sometimes people take an X-ray. Of course, yeah. Nowadays, what we do is we are very particular that we put some Otrivin or something like that, nasal drops, and we take a 2.4 millimeter endoscope and try to go inside. We try our best to go inside and just have a look at the nasopharynx. So this is a sort of protocol which now we have started following. I mean, not now, for a long time we have been following that. So the reason is to differentiate it from various other conditions. You can have a choanal atresia, you can have a antrochoanal polyp, you can have some, mass lesion. We had a big thorn wall cyst also, and that was misdiagnosed as an adenoid. So all that, you can have. So the carry home message through this particular case is that do not think that all nasal obstructions in children are due to adenoids. Now see here. So the first step is scissors. So the first step what I do is, that I press the antrochoanal polyp. Of course, you would have seen many of my videos. And then I cut off the attachment of the nasal part and the choanal part from the antral part. So having done that, now this I am sure will not come through the the nasal cavity. So I'm pressing it here. Big pack. So see here. So what a googly it was. I was so happy that I made this diagnosis. The reason was very clear because 2 or 3 people had diagnosed adenoids and advised adenoidectomy. And we can easily make out that this is not an adenoid. So there are some sort of, X-ray findings which we use to actually talk about the semilunar air shadow, all that we used to talk about. But of course, that also holds good even now. So if you find a small semilunar air shadow, give me a tongue depressor, then it is an antrochoanal polyp. If you don't find that, it is a adenoid. There you go. Hold the head. Abhi, hold the head. So here we are. I'm trying to hold this. Hold the depressor, tongue depressor, please. Come on, darling. See, this is a big polyp. Hold. Now I'm just going to take this out. So I know it's not going to come out through the nose. See that? So it's a big one. So this is the first part of the surgery. Of course, the second part of the surgery is just a routine, So I just want to see if there is adenoid. There's no adenoid. See, so what diagnosis? Backbiter, please. So we made was completely, a googly. So please, this is a very important, very small thing. You might think, this is nothing. What is he talking? It's just very small. But believe me, small things make you fall, slip and fall. So these are all things you should practice in your regular practice. So whenever there's a child with nasal obstruction, try to do a cotton wool test. Okay. So that's it. Now this is the give me a ball pro. So I'm going for the hanging technique. This is called the hanging technique. See here. So again, see that 1, 2, and then 3. So this is how we do the hanging technique. And then we press it behind. Now, once we do that, I'm just going to see another important thing I want to tell you is that if you have an antrochoanal polyp which has got a sort of a pedicled attachment, it is very easy to operate. Whereas a sessile attachment of an antrochoanal polyp, you should get ready for a prelacrimal approach. So this is something which again I want to caution you about. So we have already counseled the patient for a prelacrimal approach. Now, give me a, so what I will do right now is, give me a backbiter. So I'm going to take off this upper part of the inferior turbinate. See what I do. So I've removed the horizontal part of the uncinate process, but I'm taking off this part of the inferior turbinate. See that? So why am I doing that? The reason why I'm doing that is because I want to increase the width. Only if you get the width, you'll get the depth. So this is the first step I'm doing so that I can see inside. Now give me the RAD 40, please. Give me a big pack. So here we are. So almost done most of the surgery except the antral part. So what do I do for the antral part? I just keep a pack nicely here. Give me a J-curate. So should we do a prelacrimal approach? Is now going to be my decision making based on what the attachment of this polyp is. So here we are. I'm trying to put that right inside. So this is packed with adrenaline. Just pack it inside and then swirl it nicely. As you swirl it, what happens? You actually reduce the size of the polyp At the same time, you can see where the attachment site is. Okay. Now give me a 70-degree telescope. 70, please. Mm, mm, mm. 70-degree telescope, please. Pudusa, is this new one or? Okay, now I'm just going inside. This is the old one, mine. Give me a new one. Okay. Now give me a upturned Blexley. Now comes the important decision making, whether I have to do a extended extra approach or can I manage with just this middle meatal antrostomy. Okay. Now I think, give me a RAD 40 please first. So what I'm going to do now is, I think this is the site of attachment according to my assessment. See here, this is the site of attachment here. This is the site of attachment. So what I will do now is again try to get this medial wall out. Give me a tuck tuck please. Tuck tuck. Quickly tuck tuck. Now you have to tap it. See what I will do is I'll take this out. See what I'm doing. Just take this out a little bit. Now tap. Tap. Good. Now again tap please. Tap. That's it. So after this, what happens is that you just take this out. Give me the new 70-degree. I think you have to send it for refurbished. This one change. So these scopes get a little dull when it ages. I'm attaching a new 70-degree. Okay, wait for so. So I'm attaching a new one. You see how different it is. You look at this compared to that. This is actually ah. Yeah. What's happening? Suction. Hey, இது 70 அது இது ஸ்டோர்ஸ் இல்லம்மா இது என்னம்மா see don't use the Chinese 70. Chinese 70 is such as the worst scope I have ever seen in my lifetime is a Chinese 70. So if it is 70 it will be 120-degree. That is what I never use Chinese scopes for surgery. Surprisingly all my fellows they use only the Chinese scopes. Really don't know how you guys operate with the 70, man. This is not true 70. It is something like 90. They don't measure the angulation, you know. They just make some degree. That's it. சொல்லிட்டாங்களா? ஆமா. Change the 70. Now you see how much difference it makes. I put the Chinese 70 and then the 70. And you see now how perfectly you can see them image. See that? See that's the difference. Okay. Okay. Now, okay. Now give me a Blexley, please. See the difference, huh? You can see the old Karl Storz 70, the Chinese 70, which was just so bad. Give me a RAD 60 now. So I am now going to fanatically open up so that this child doesn't develop a recurrence. That's the idea. Give me a rad 60. Now I'm going to take a 60-degree debride blade. I'm going inside now. Irrigate, irrigate. Irrigate. Good. Enough. So this is where I think the attachment is. Oh, it's attached more anteriorly. So don't go any further anterior because that will clearly cause a nasolacrimal duct injury. We just saw one patient, you remember, Kabilan? Somebody had done a FESS and patient presents with epiphora. Give me a backbiter. So you should be very careful about the nasolacrimal duct. Don't damage the duct at any cost. See, even when I'm doing this, I'm not biting it, I'm just pulling, that's all. So the duct will be somewhere there, definitely. Okay. Now see here, this will be, give me a tuck, please. So I have to examine all the walls very, very, very thoroughly so that okay. Now having done that, now am I give me a backbiter again. Let me take off this. I think I've done it. What about that? That doesn't look like a polyp. Little scared when I do this. I don't want to cut off the nasolacrimal duct. I'm just pulling it. I'm not trying to bite it at all. Just pulling it. These are all important maneuvers to learn. So here we are. Am I seeing some sort of give me that 60 debride blade? So here we are. I think I'm done mostly with this case. What about here? This doesn't look like polyp, right? Oh, that is not. Yeah, I think I'm done. Give me a backbiter now. I want to take off this bone. I don't want that bone to be there because that might produce osteitis. Okay, that's fine. So that's the end of the surgery. So, of course, even though it was a small, simple surgery, the carry home message was very powerful. So, whenever a baby comes, always try to do a cotton wool test. So that's the idea of the whole surgery, right? So thank you very much. Have a nice day and God bless you.
Sir, good morning, Rajendra sir.
Hello, sir. Hello. How are you?
Sir, fine, sir. Fine, sir.
So yesterday also I did live. I didn't see you.
I'm busy, sir, yesterday.
Yeah.
But
Just
I'm missing you. I will join.
no.
Sir,
May is busy for everybody, so I can understand.
yeah.
I can understand.
Hi, boss.
Sir, evening, what time you are free?
Evening, what time I'm free?
Yeah.
Why?
Just I want to talk to you.
Yeah, maybe around 5 o'clock.
Okay, sir. Thank you, sir. Thank you. Nice,
Thank you, boss. Thank you.
nice surgery, sir. Nice
Thank you,
surgery.
sir. Thank you.
Simple and immediately within a few minutes it is done.
Thank you. Thank you.
From Dubai, thank you, Doctor, boss.
Oh, hi. Thank you so much. Hey, I heard Dubai, they are bombing too much.
Yeah, me.
Okay. I'm praying for you. I'm praying for all of
Thank
you.
you, boss. Yeah, thank you. I'm Shawak, Dr. Shawak.
I can see. Dr. Wag. Thank you. Thank you. Thank you.
Sir, when you come to Hyderabad?
Hyderabad, I'm coming on 18th.
Okay, sir. Okay, sir. Thank you, sir.